So welcome everybody and happy post-election. I'm sure we're all quite relieved that that's all over. The brave new chapter ahead of us. And just a couple of quick announcements. I posted in the chat information about the stigma survey, which is now up and open. And just as a reminder, this is for anyone who is living in the Coachella Valley, who is over 50 years old. And we're looking for both positive and negative people. So there's a link for positive people, that's the one on top, one for negative on the bottom. So, and there's a $20 gift card incentive. So we want to make sure you're reimbursed for your time and can do some online shopping and share it with all your friends, positive and negative. So all you have to be is over 50, which is not hard in this town. And then one other quick announcement. I've been approached by a group that's putting together a video on Stop HIV and LGBT seniors. And they are looking for older LGBT folks, both positive and negative again, and they want, really diverse people, trans, of all colors and faiths and creeds. So if you're interested, shoot me an email and I can give you the information, or put you in contact with the video producer. But they're looking to put this together next month. So if you would like your 20 minutes of fame on video, here's your opportunity. So speaking of fame and fortune, we have the good fortune of having the famous Dr. Palefsky joining us this evening to talk about his favorite topic in ours, HPV. And so welcome back to the desert, and take it away, Dr. Palefsky.
Thank you, Jeff. Can everybody hear me well? Okay. I am going to screen share. People can see that? Okay. So thanks very much for the invitation, Jeff. I wish I could be there. This is the first time I'm giving this talk for the Palm Springs group this way. I've been down there many times by now. Would have been happily eating my dinner with you guys while waiting for 6:30 to come. But that is not meant to be. So today we're going to do it a little differently. But I'm glad to have this opportunity for a couple of reasons. One is, as time goes on, there's always new stuff. And one of the most important new things is that the anchor site at Desert AIDS has opened. And there is new opportunity now for people in Palm Springs to participate in the study. And I know David is going to have something to say after I'm done. So I'm hoping that the information that I give you about anal cancer and about the anchor study will stimulate more people to harass David until they're randomized into the study. So let me just get my laser pointer back. Here are just some disclosures. I always like to give these so you can decide whether I'm full of it or not. I'm doing some work with Merck on the vaccine and with a bunch of other companies that are associated with the various therapeutic options. Oh, I just realized that this is help you understand the latest, greatest on the epidemiology of anal cancer in people living with HIV. I will use the terminology PLWH moving forward. To understand the current epidemiology of anal HPV and the anal cancer precursor HSIL in PLWH, and to understand why anchor is so important in this story. So just to remind those of you who know this, and for those of you for whom this is new, that the idea here is, now this is skin we're looking at, that people get infected with HPV, human papillomavirus. Most of the time nothing happens, you get normal skin, this is normal. But in a few people, they get either what's called low-grade disease. The best example of that, the most common example is warts. Warts are very annoying. Nobody likes them, but they don't kill anybody. But a less common but more serious version of that is what we call high-grade disease, high-grade squamous intraepithelial lesion, or HSIL. This is the precancerous lesion. And this is the lesion that if we leave it alone long enough in some people, it will turn into cancer. And that by definition happens when these cells that sit on this floor called the basement membrane break through the basement membrane and invade the tissues underneath. These cells then continue to divide, they make big lumps, and they spread to other organs and block vital structures, which can lead to the death of the person. This is a really important point because the whole structure of the cervical pap smear screening system is to find this lesion in the cervix, because the cervical cancers and the anal cancers are very similar and both preceded by this high-grade lesion. And if you can find this high-grade lesion and remove it, we know, at least in the cervix, that you can prevent a lot of the cervical cancers. So that low-grade lesion, again, is not precancerous. In fact, it's the version that carries the most infectious virus. So if you were going to have, say, sex with somebody and you were not wanting to get HPV, ironically, you would probably rather have an encounter with somebody who's got the precancer than somebody who's got a wart, because they are probably less infectious to you. So why do we care about anal cancer? It's not on the front of the brain of many people. It's not a very common disease. People really don't talk about it much unless some famous celebrity gets it. But it is important, and the reason is that unlike almost every other cancer, this one is going up in the United States and has been since the 70s. In fact, it's been going up by about 2 to 3% every year amongst both men and women, men in blue, the women in pink, very original. And the point, though, is that because the rates of anal cancer are so much higher in MSM living with HIV, as I'll show you later, that in the minds of the public, anal cancer and MSM living with HIV have almost become conflated. In fact, that's really wrong. And as you can see here, anal cancer is more common in women in the general population than men, much less HIV positive men. In fact, though, if you look at more recent data, in women who, in the general population of white women 65 and older, anal cancer is now more common than cervical cancer. That's the, oh, this is annoying. The yellow, the orange is anal cancer, the red is anal cancer, the orange is cervical cancer, and the two lines have crossed. So you're going to be hearing a lot more about anal cancer, I think, as we move forward. But I want to put this in context and show you where those rates are in the general population, and then how they look in the setting of HIV. So here, down here at the bottom are the rates per 100,000 years in men in the general population in blue and women in the general population in brown. Now look at the rates in people who have HIV infection. This is a log scale. So here you're less than 1 per 100,000. Here you're easily more than 10. So the lowest group are the women, followed by men living with HIV who are not MSM, followed by the group by far at the highest risk, which are MSM living with HIV. So you can see there it's roughly 100-fold higher in MSM living with HIV. And you can see that the rates have gone up and more or less stabilized in the years 2005 to 2008. And I'll show you some more about that in a bit. This is a very recent publication, which again puts it in a whole different context, which is to rate the anal cancer risk scale, where red is the highest risk and green is the lowest risk. And you can see that the groups here at the bottom are HIV uninfected, non-MSM, HIV negative in the general population, and even people who are immunosuppressed, but who don't have HIV, they're immunosuppressed for other reasons, Crohn's disease is an inflammatory bowel disease, but not that highly associated with anal cancer. There's an intermediate risk group, still quite high actually. This intermediate risk group is between 15 and 35 per 100,000. And to put that into context, cervical cancer in this country is about 8 per 100,000. So this is not nothing. But you can see, for instance, that in this intermediate group, you have non-MSM who have HIV. You have women who don't have HIV, but who may have other HPV-related cancers or precancers, such as vaginal or vulvar cancer or precancer. The group at the highest risk that doesn't have HIV actually are women who are more than 10 years out after having a kidney transplant, because they get a graft, and to prevent rejection of that graft, the doctors give the women drugs to prevent rejection, which are immunosuppressive. So that doctor-caused immunosuppression leads to increased risk of anal cancer. But if we swing over here onto the left, you can see again the group that is at the highest risk. And the highest risk is proportional to age to some degree. The 30 to 44-year-old group is the lowest risk, gets quite a bit higher in the 45 to 59, and then even higher as you get older. So I think this is a nice diagram because it really puts that risk into context. So what are the risk factors for anal cancer? Far and away HPV, and far and away of the HPV types, of which there are over 200, HPV 16 is the biggie. Probably more than 90% of anal cancers are associated with HPV 16. But there are other factors that typically are associated with HPV acquisition, which are also independently associated with anal cancer: having multiple sexual partners, having anal warts. Remember, I said that warts are not precancerous, so this may seem like a contradiction. And the reason these are a risk factor, we think, is not because the warts are causing cancer or turning into cancer, but rather whatever behaviors you had that gave you the warts probably put you at risk for getting the bad HPV types also, like HPV 16. Having anal intercourse is a risk factor, not surprisingly. And as I alluded to a little bit earlier, women who have other HPV-related diseases in the vulva, the cervix, the vagina, are at increased risk of anal cancer, even if they don't have anal intercourse, probably because there's still ways to spread HPV from the front to the back. And so women are at increased risk of anal cancer, either if they have anal intercourse or if they have one of these diseases in the front. Smoking is an important risk factor. We know that when people smoke, their levels of tar and nicotine are actually higher in the cervix than there are in the blood. So there seems to be like a concentrating effect of cancer-related compounds where you least want them, which is in the presence of cells that are also infected with HPV. And we also know that cigarette smoking reduces the activity of local cells that are responsible for the immune response. So they're locally immune suppressive down there, even if you're smoking, up in the lungs. One of the reasons I focus on tobacco so much is because it's one of the few things here that can be changed. When you talk to patients and you explain to them this, sometimes it gives them a little bit more of an impetus to try and at least cut down, if not stop altogether. And as I mentioned before, also when you're immune suppressed, that increases the risk. You need that immune response to fight off HPV. Almost all of us get it. 75 to 80% of us get HPV. We know that 75 to 80% of us don't get anal cancer. So most of us are fighting it off successfully. It takes that immune response that's not antibodies, but it's called cell-mediated immunity. And when you lose it or you get it reduced by various immunosuppressive events, such as HIV infection or immunosuppressive drugs, then that virus that's sitting around there could potentially reactivate and stay active and cause those diseases that we've been talking about. Another big question is, what about ART? So you know very well when ART became common, it was dramatic. People started to live longer. Now people live nearly, if not completely, normal lifespans at this point. So HIV has turned into a chronic disease. And a lot of the diseases that used to be associated with uncontrolled HIV infection have been reduced. Some of the other cancers that are AIDS-defining cancers have come down. Kaposi sarcoma, non-Hodgkin's lymphoma. They have come down, but I did not say they've gone away. And in fact, there are still big problems. And one of the diseases that is still a big problem are the HPV-related cancers. One would hope, for instance, that if you had this HSIL precursor, it's not even cancer yet, and you go on ART, that new immune response will make that HSIL go away and your cancer rate will go down to the same level as if you had no HIV at all. That unfortunately has not happened. Instead, we see relatively little beneficial effect of ART on HSIL. It sticks around. But if you live longer and you're not getting screened or treated, you're at risk for higher rates of cancer because you have longer for those lesions to progress to cancer. So we had actually predicted that when ART became available, that rather than seeing the kind of reductions that we saw with KS or non-Hodgkin's lymphoma, that actually anal cancer rates would go up, primarily because at the time, and still to this day, there's no formal active screening and treatment program to prevent it. One good piece of news, though, is that it's not like ART has been completely useless in this context. It actually has had some benefits. So we saw this big increase when ART came around. It leveled off at a ridiculous rate. And in the last few years, it has started to come down some, but it's not going to come down to the level it needs to be. It is still at a level which is way too high. And I think it would be a great mistake to say, let's just wait and see what happens. So where anal cancer is going in the setting of PLWH is actually rather complicated. There's a lot of different factors in both directions here. I think I still hear me a little bit in the background. Sorry about that. Basically, getting older is a risk factor for higher incidence. Not much we can do about that. That's mostly a good thing. One thing that will help a lot in the future is vaccination, but it's going to take time. So when you look at future indicators of where this is going, one can look at two things. One is how common is HPV infection? If you don't have HPV infection, you're not going to get anal cancer. The other is how common is HSIL? If you don't have HSIL, you're probably not going to get anal cancer. So here we can look at the prevalence of HSIL or HPV in risk populations, HIV, negative MSM or MSM living with HIV. And the picture here is a little bit distressing, actually. What we find, and this is an older study, but it's the only community-based study that I know of, so I'm showing this to you, is that in one single cross-sectional analysis that we did in San Francisco, 72% of the MSM with HIV had anal HPV infection with one of the cancer-causing types. And 34% of HIV negative MSM had a cancer-causing HPV type. If you throw in all the other types, those numbers get even higher. What about HSIL? Well, actually, before we get to that, I want to show you in women, it's even more interesting in some ways because it turns out that in women living with HIV, the prevalence of anal HPV infection is even higher than cervical HPV. This was, again, a study that we did a while ago, but which has been replicated many times over, showing that in women with different CD4 levels and a group of high-risk HIV negative women, in gray is the cervix and in blue is the anal infection. You can see in all of these groups, anal infection is more common than cervical, and that those numbers also go up the lower your CD4 level. This is not as clear now that we're on ART because the meaning of CD4s isn't quite as clear as before when we weren't influencing it with ART. Interestingly, these kind of studies led to broader studies in the general population of women. And in most studies of women, regardless of whether they're high risk or not, whether they have HIV or not, anal infection is at least as common as cervical infection. Now, what about the squamous intraepithelial lesions, SIL? If you look at the cancer precursor, HSIL, in that cross-sectional study, we found that 43% of the MSM living with HIV had HSIL. This is enormous. In fact, some of our more recent studies show more than half of the population have HSIL. Let me put this in a little bit of context for you. If you were to do a random sampling in, say, San Francisco of healthy women, you would probably find that less than 1% have a cervical as high-grade lesion. So this is a big issue. Surprisingly, a quarter of the HIV negative MSM also had one of these high-grade lesions. We've also done a study recently in the AIDS Malignancy Consortium, AMC 072, which we've submitted for publication, showing that these high-grade lesions actually develop quite early. We did that study. It was meant to be a vaccine study of young MSM living with HIV, 16 to 26 years old. And what we found was that in those guys who were mostly 21 to 26, about a third of them actually had a high-grade lesion already at that very young age. When you look at the risk factors and the prevalence of high-grade disease in women living with HIV, overall the prevalence is lower than in the men, but still quite high, 27%. That's big compared with cervical HSIL. And if you look at the risk factors in this study, also an AMC study, the risk factors, interestingly, are cervical stuff. Having abnormal cervical cytology, having HPV infection in the cervix are risk factors for anal HPV associated HSIL, as well as having abnormal anal cytology. So this is all consistent with the role of cervical HPV infection in anal disease in women. Now, one of the big questions is, if 43% or more of people living with HIV have HSIL, are we on the verge of a public health catastrophe? If all of these were going to progress over time, we would have millions of cases of anal cancer. So the good news is that is not the case. We know that's not the case because the rates of anal cancer are more like what I showed you before, 100 per 100,000 per year. So 1 in 1,000 per year. But when you do some calculations, and this was published in a meta-analysis a bunch of years ago, the estimate was that for MSM living with HIV, 1 in 377 per year might progress to anal cancer. That doesn't sound like a lot, and it's not. And it allows me, when I'm talking to patients, to make sure that the panic button has not been pressed. The individual risk of progression is quite low. However, this is per year. And you could imagine that if you have that high-grade lesion in your 20s or 30s, like I just told you for that study we just did, if you multiply that by the number of years that we hope somebody's going to live, it starts to add up. And the estimate is that if people get that HSIL early and it sticks around and they live into their 60s and 70s, that the lifetime risk of anal cancer could be as high as 10%. So that's, I think, not acceptable. The numbers, fortunately, are quite a bit lower in MSM who don't have HIV infection. But the other thing, though, is that these numbers did not account for whether or not someone had HSIL. So if you assume that you have to have HSIL to get anal cancer, and you now ask what is the rate of cancer in people who have HSIL, since only half of the population has HSIL, one could expect that these numbers are probably double what I'm showing you here. Okay, so really what we think is it's more like 1 in 200 per year for people who have HSIL amongst MSM living with HIV. So Again, not a high number on an annual basis per person, but over time could be very substantial. So what do we do about all this? Again, the cervical model, since cervical and anal cancer are so similar, is that cervical and anal cancer are very similar diseases. They're both preceded by HSIL. We know after decades that cervical HSIL treatment reduces the incidence of cervical cancer. So the assumption is that if we do the same in the anus, then we'll reduce the risk of anal cancer. This is something that we could potentially do something about. But before we go ahead and start doing all the things that we think we need to do to get a program like this in place, we have to answer some tough questions. One question is, we're making an assumption it's going to reduce the incidence of anal cancer, but do we know that that's true? And the answer is no, we don't know that's true because nobody's done the study to prove that. And I'll show you what's involved in doing that study. Because we've never done that study, because we don't have the data yet, a lot of people are saying, namely insurance carriers, well, we don't have proof that this works, so we're not going to reimburse you to do these procedures. And so since the reimbursement is a challenge, it also has discouraged people from getting trained to do it and building up a big enough core of clinicians who are capable of screening for these high-grade lesions and treating them. Another very big question is, even supposing that it does work, supposing we can prevent most cases of anal cancer, what if we make people so miserable in the process that they may say it's not worth it? They may say, you've ruined my life, I'd rather take my chances on getting anal cancer. So what this ultimately comes down to is a risk-benefit analysis, harm versus benefit. And one of the most important tenets of a screening program is that the overall benefit of screening and treatment, of course, should outweigh its potential harms. So starting off with that assumption that anal treatment might work to reduce anal cancer, and you may ask, why is it just an assumption? What could happen that means it doesn't work? Well, the issue here is that the populations who are at the highest risk, PLWH, also have the most challenging disease. They tend to have the biggest lesions. They tend to have the highest number of lesions in the biggest number of different areas. They're large and multifocal. And that means that the risk of treating some HSIL is higher than if you have, say, one or two small lesions. And if you don't treat it all, then that's the stuff that could potentially progress to cancer if you leave it alone. Getting trained in high-resolution endoscopy, and David will attest to this, is not a simple matter. It takes a long time, a lot of dedication, a lot of skills building, and even the very best of us still miss lesions. They can be quite subtle. So again, if you don't treat it, you may not prevent it from progressing. Even if you see it, doesn't mean you're going to treat it completely or adequately. So clinicians may not treat them in total enough to prevent that progression. And then another big one is that I may see an area that I want to treat on the right side of the person's anal canal, and I finally succeed in getting rid of it, but they come back a year later and now they have a new one on the left in a totally different area. There's a medical term for that. We call it metachronous disease. It probably results from having pockets of HPV that are sitting around dormant for the most part, but that reactivate for whatever reason. Because when we're treating lesions, we're not treating the virus, we're just treating the areas that we see. And most of us who've had HPV probably have little bits of dormant HPV all over the place. And for most of us, that's not clinically relevant. We don't get into trouble. But if you have some degree of immune suppression, it could be a problem. So I call this anal whack-a-mole. So the answer to moving forward with a screening program will require getting the data as to whether treatment works, and that's what the ANCHOR study is for. ANCHOR stands for Anal Cancer HSIL Outcomes Research Study. It's a study that's funded by the National Cancer Institute, who deserve a huge shout out. They really, if you'll pardon the expression, have had our backs from the very beginning. And the Office of AIDS Research, this is one of the biggest studies ever done actually on a population living with HIV. The most important aim of this study is to answer that basic question. Does treating anal HSIL reduce the incidence of anal cancer in men and women living with HIV? There are a couple of other, or three other important aims. One is to determine the safety of our treatments. This is not a study of a specific treatment. It's what we call a strategy study. I'm going to treat or I'm not going to treat, and it's up to the clinician to decide what kind of treatment they're going to use within the bounds of the protocol. But we need to know that they're safe. And as I was saying before, it's got to be done at an acceptable cost with respect to impact on quality of life. And so we developed a new health-related symptom index for Anchor called AHERC to ask questions about anal health and its impact on your life. When we started this study, there was no validated questionnaire to do this because nobody gives a rat's ass about this disease except for us. And so we had to start from scratch. So this is finally in place. The fourth one is extremely important too, because we're going to be collecting, we are collecting specimens and data to go with them as we go along that are being deposited in a biobank. The biobank is in a not so obvious place. Where do you want to keep a minus 80-degree freezer? In Tucson, of course. What it's going to allow us to do is to analyze tissues before and after a person progresses to cancer, if they progress to cancer. And by being able to compare those HSIL tissues to the cancer tissues, we can learn a lot. What's changed? Is the thing that changed something that might allow us to predict who's going to progress and who won't? So this is super important for helping to understand the biology of progression from HSIL to anal cancer, and gives us the opportunity to develop biomarkers that tells us who we need to treat and who we don't. Because if we can't figure that out, we're stuck with treating at least 43% of the population if we determine that treating HSIL really does reduce the risk of anal cancer. And that is a very daunting proposition. So how do you do a study like this? One of the things that I first presented when I came down to Palm Springs years ago was to present this basic idea as we were still designing the study and preparing it for submission to the NIH. It basically is what we call a randomized controlled trial. It's not blinded or double-blinded, but it's randomized, where we determined that the only way to really answer the question about whether treatment works is to divide people who have been shown to have anal HSIL into two groups, randomized 50-50 by a computer, treat one half of them and follow the other half very closely. And then count up the number of cases of cancer in both of these arms over time. So one of our big concerns, of course, was the ethics of doing that. And that was one of the things that I wanted to present to the Palm Springs group and get some feedback on that. And I will say that after presenting all the reasons for it and all the pros and cons, that the group was pretty unanimous that this was okay. This was very encouraging to me. And in fact, we have passed through the ethics boards of probably about 25 different organizations at this point without any comment. And the reason that it is okay to monitor people with HSIL, even though we're concerned that they might progress to cancer, is that we don't know that the intervention in the other arm is really helpful or not. So the idea is that we screen men and women with HIV who are over 35, because remember, it's the older people who are at highest risk. And if we enroll a bunch of young people, nobody's going to get anal cancer, and then we'll never get an answer to the question. So over 35, and if they have HSIL, they get randomized and treated in this group, or just monitored very, very carefully, much more carefully than if somebody was not in a study and much more carefully than if they had no access to examination at all. So we count up the number of cases of cancer, present those results to a data and safety monitoring board, and they tell us, continue the study, or there's not enough difference between the two arms that you'll never show a difference, so you stop the study now for futility, or you've already shown such a big difference between cancer rates in the two arms that you don't need to do the study as long as you predicted, and so you can stop the study now for efficacy. It so happens we're having our next data and safety monitoring board meeting on Friday, and they will tell us one of these three things on Friday. So this is a big study. The plan is to enroll 5,058 people. And unless the DSMB tells us to stop early, follow people for 5 years after the last person is enrolled. So since this is a big study, we need to do it in multiple sites. This shows you where we have sites around the country. They tend to be in areas with the biggest concentration of people living with HIV, mostly along the East Coast and the West Coast, and a few stragglers in between. And of course, we have Palm Springs down here. So what I will tell you is that at this point, these are data as of last night. We've already enrolled more than 4,000 people. So again, the goal is 5,058. And we were hoping at the rate that we were recruiting that had COVID not come along, we would have been completed with the enrollment in about 6 months or so. But that's thrown us back by at least 6 months, and it'll probably be another year from now, my guess, until we're completely done. And you can see the numbers of people enrolled does vary quite a bit from site to site. Let's look at Desert AIDS. Here we are, 39 individuals enrolled so far. So David, keep up that push to get more people, and I'm hoping that the people sitting here listening to this are going to be inspired and either come in for screening if you're qualifying, or talk to every single person you know about this. Pretend it's an election. So just give you a little bit of data about what we know so far, about what I can tell you. One is that until COVID came along, the most common reason that people would get screened but not enrolled is that they didn't have HSIL. Remember, not everybody has it. Now, of course, we have this new section here, which is COVID-19. These were folks who started the screening process and then stopped it because they couldn't come back in because the sites shut down for a period of time. When you look at the randomization, people who are enrolled over time, we have enrolled 16% women and 84% men. Our goal is actually 20% women. So we're not that far off, but we're really trying to push sites to screen and recruit women for the study. What about gender identity? In terms of cumulative randomization, actually about 4% of our participants self-identify as transgender. That sounds low, but actually it's higher than the overall proportion of people living with HIV who self-identify as transgender. So we're actually a little overrepresented, but I'm still pushing everybody to work really hard to enroll as many transgender people as possible. And then as far as racial and ethnic background is concerned, this is one of the biggest studies in the country, enrolling high proportions of underrepresented minorities. So if you look, for instance, at cumulative data for randomized participants amongst the men, 23% are Hispanic and nearly 35% are African American. If you look at the women, the numbers are even more impressive, 28% Hispanic and 59% African American. So we're really proud of that. It's an accomplishment, but we want to get as many different kinds of folks in the community screened and randomized. The other thing that's interesting is that the mean age of the people who are randomized is a little more than 53. So that's pretty good for us, actually. Remember, those rates of anal cancer go up with age. We don't want to get people with such a high risk of cancer that will be overwhelmed with it. And we don't want people too young for the reason that I mentioned. So 53 is sort of the Goldilocks number from my point of view. COVID-19, as I mentioned, gave us a hit. We had to stop all of our activities for a while. As we were shut down, we still made provision to see people who needed to be seen emergently. There weren't very many of those folks, but that was important to do. So we set up protocols to see patients on an emergency basis. And then as things eased up a little bit, we established criteria to allow sites to reopen, and Desert AIDS is reopened now with the appropriate precautions for COVID-19, and David may have more to say about that. And we wanted to make sure that all of the sites were proposing new procedures that were consistent with protecting people, participants and staff as much as possible. One of the things that we've established as a new policy quite recently was for those who want it, we will reimburse people to have private car rides, Uber or Lyft, or public transportation if that's what they prefer. And in some places, every city around the United States is quite different with respect to the transportation needs. Palm Springs is not the same as New York City, for example. But we will reimburse participants if this will help them feel more comfortable about coming in and staying in the study, because study retention is obviously very important. So at this point, all of the sites have reopened. We are not back up to full blast at this point. Activity does vary from site to site. Overall, I'd say we're about somewhere between 50 and 80% of pre-COVID capacity, roughly about 75% on average. And again, we needed to prioritize when we reopened. And my priority that I suggested for the group was to focus on making sure that the people who are already in the study are missing their visits as little as possible. So to focus first on people already enrolled, and then as capacity increased, then focus again on seeing new people to get us closer to completing our enrollment. We also have two other things planned for people who are going to be screened and enrolled moving forward. One is that questionnaire is going to be implemented, that quality of life questionnaire. So everybody who is screened will be approached to ask whether they're interested in participating in this, and they'll be eligible for it if they're enrolled. And then they'll be followed over time, depending on where they are in the study at different intervals, to see how being treated may have affected them, or if they're in the monitoring arm, being monitored. Does being monitored cause a lot of anxiety, or one could anticipate different kinds of impact of quality of life depending on which arm you're in. The other one is since SARS-CoV-2 is around, SARS-CoV-2 is the virus that causes COVID-19. You know now that we have what's likely to be a successful vaccine. It's going to take a bunch of months to get everybody vaccinated. But one interesting thing that transpired was we learned that there's virus not just in the nasopharynx or in the mouth where they typically test people, but also shed into the stool. And the reason for that, we think, is because the virus not just infects the lungs, but also the GI tract, the gastrointestinal tract. We don't know yet whether the virus infects the anus specifically, which is just the last, couple of centimeters of the gastrointestinal tract, but it's the part that we're interested in, because that's where the cancers arise, and that's where HPV causes cancer. So we are going to be doing the first study in HIV positive MSM to look for anal infection in people being screened and enrolled into Anchor at 5 study sites. We don't have the funds to do the study at all sites, so we're doing the study at some of the higher enrolling sites right now. But the idea here is that we will test for this virus in the specimens we're already collecting as part of the anchor study. The only additional sample that we're going to be collecting for people who enroll in the study is an oral swab, just to compare the results that we're seeing in the anus with a more standard oral sampling, so we can get an understanding of what the relationship is between the two. So these are going to be things that we're going to be implementing as we eventually make our way to completion of enrollment. So that is my sort of overview of the study. Thank you very much for your attention. Thank you for participating. If you're a participant already, please consider enrolling at Desert AIDS now if you're eligible, i.e. have HIV and are 35 years and older. I don't see too many people over 35 on the participants here, but if you are, please consider it. And again, please encourage your friends who might be eligible to do that. So I would be very happy to take questions, and hope that this was interesting for you.
Great, thank you. That was terrific, Dr. Palefsky. Applause all around. And yeah, go ahead and either raise your hand, use the little raise hand feature, or just put your hand up like this. Or if you're shy or your audio isn't working, you could type it in the chat box as well. Yeah, Frank, go ahead.
I'm very, in my earlier years in the medical field, I have probably screened pap smears for over 2 years from the vagina. I didn't take them, I read the slides, but I'm very happy to hear that there's a correlation pretty close between cervical and rectal cancer. Because I have a friend that has a problem and he's not dealing with it. And I can see that he was infected between the ages of 13 and 18 because of the progression of his rectal cancer, and the biopsies that were done because of Dr. Schoenberger. Said he's right. I mean, I forget his name. I mean, he was at DAP, but it was so bad that they had him go to Desert Regional with Dr. Johnson to do 9 biopsies. So this is very, well, I'm very much involved with it because of my friend who is not paying attention to it. So, but thank you so much for this presentation.
Thank you.
Great. Anybody else? Oh, I see Paul. Go ahead, Paul.
Yeah, Joe, I hope you can hear me, but I had HPV when I was 20. I did start the anal swab. I lost my doctor in June. He retired. I was assigned another doctor. He's left. He told me something else about doing the anal swab. Now I'm getting a new doctor in March. My question to you is, how often should you do the anal swab? And second question, does your CD8 count play a role in this? Because we always talk about our CD4 counts, but my CD8 count's like really low.
And that's a really good question. So as far as how often it should be done, that really depends on what was found at the previous one. So if you're normal, then, and you have HIV, then I usually say every year. If you have some abnormality like L-cell, low-grade disease on the cytology, then I usually say every 6 months. And if you have H-cell, you shouldn't bother with it. You really need high-resolution anoscopy with biopsy. In fact, I would say if you have any abnormality at all, you're best off to get an HRA in the first place, because cytologies are actually a pretty bad screening test. They undercall disease, they miss a lot. And so if I had my druthers, if HRA was easy to do and we had a ton of people who know how to do it, we wouldn't even bother with these screening tests. We would just do HRA on everybody. But one thing that we're doing a little more these days to try and sort this out is HPV testing along with the cytology. So for example, when I take a swab, we send it to the pathologist to read the slides. Usually the material is left over from that can be tested for the virus itself. And if somebody said to me that the cytology was normal, but you had HPV 16, then I'd say you need HRA. If you have an L-cell, a low grade on cytology, but no cancer-causing HPV types, I'm really not that worried about you. So it's a combination of different things and depends on what people are doing. But the best answer for all these questions is go and get screened at Desert AIDS Project for Anchor.
That's
Great. Thank you. Any other questions? Oh, George, yeah, go ahead. You need to unmute. You got to unmute, George. There you go.
I
Done.
lost my doctor who did mine, Dr. Scheibel, I guess 2 years ago. And I'm not aware of anyone who's doing the screening because I got screened and I was low grade dysplasia. And he recommended every year, and it's been 2 years. And I thought that DAP, was his name Matt
Moran.
left.
Yeah.
Yeah, and so I didn't really know who to get in touch with now. And then plus COVID-19 caused, I kind of figured they don't want to be bothered with us right now.
Yeah, well, we do.
Okay.
David, maybe he's going to kill me after this presentation. I don't know. But the right answer
I
is that today is open for business. And I think it's a great opportunity for you to get really good care by getting screened.
And his name is David at DAP?
David Morris, he's on the call. He's
Yeah,
Okay.
George, I'll answer that in my presentation.
Okay. Thank you.
Sure.
Yeah, just so people know, we're very fortunate that Dr. Palefsky and his team have trained a lot of really good endoscopists here in the Valley. So we're very fortunate here that not only DAP, but also Eisenhower, Borrego did, and unfortunately they lost both Dr. Scheibel and Shigeno. But both Eisenhower and DAP have good, well-trained endoscopists. So it's here in the Valley. It's available for those who want it. Any other questions? If not, I'll bring up Dr. Morris's slides and we'll have him go next. Here you go. All right, Dr. Morris, take it away.
Okay, great. Joel, thank you for your very eloquent and very educational presentation that you did. It's a great segue to me talking about the program we have here. I also want to thank Joel and all the people at Anchor. We were one of the last 2 sites selected in the nation for DAP for this NIH study. So I'm the private investigator for Anchor at DAP, also the chief medical officer at DAP. And the next slide will show you our fearless warriors. Greg Jackson on the left is the research coordinator for DAP. I'm next as the PI. Anthony Valesco is next. He's our nurse practitioner that's been credentialed through Anchor. He's been doing HRA probably 2 years plus and is credentialed both at HRA and for treatment. And then Michael McIntosh is one of our MAs who's helping Greg to help run this program. We're currently down to 1 HRA anoscopist, that's Anthony. And Joel, you'll probably be very pleased to hear this. We think we're within 4 weeks of having another HRA anoscopist, probably from LA, that's been involved in Anchor there. We're in the very last stages of negotiating a contract to do HRA and work on our Anchor study to be here at least 3 days a week dedicated to that. So we think we're very close to tying a deal, getting our second HRA specialist in here that's worked in Anchor for several years before now.
Now you're going to make my wheels turn to wonder who the secret person is. But
yeah, well, I'll tell you very soon. It's a little premature. We're probably within 1 week or so. We're hammering down the details of it. Okay, next slide, Jeff. So I put together just a few bullet points about the program at DAP. Some of the first part is a little repetitive. In order to become part of the program, you have to be HIV positive, over 35 years old. And again, this is open to men and women. There can be no prior history of anal cancer, no prior history of HPV related cancers, i.e. cervical cancer in women, and no prior treatments for anal dysplasia within the last 6 months. It's okay if you had them beyond that, or a year ago, or 2 years ago, or 3 years ago. And one of the things we discuss on screening with patients that are interested in the program is that patients really have to be available for appointments. They have to show up, at least 2 HRAs, maybe more per year. And as Joel said, this particular study is probably going to go on another total 5 years once it's closed to the enrollment process. And our people we take into the anchor program do not have to be a patient at DAP, or they don't have to be a client at DAP. You know, once you come here in that program, you know, you'll be part of DAP and part of the anchor program. And we have accepted transfers from other anchor sites, Los Angeles, San Francisco, Colorado in particular. We've had 1 or 2 of our patients transfer out. We just had one go to Atlanta in the last couple weeks. Okay, Jeff. So what to expect if you come to DAP, if you're going to look at being screened and look at coming into our program. The initial screening interview will be with Greg and the staff. That'll be about an hour. And then there'll be your first HRA. That procedure really is about 1 hour. It can be between 30 minutes and 1 hour, but we usually give 1 hour per HRA at DAP. And again, the HRAs will be done at least twice a year. The open enrollment for Anchor in general across the nation is, we're projecting the open enrollment will go through the end of December 2021. It was scheduled sooner than that to close, but because of COVID, that's pushed that even further. And then again, up to 5 years ongoing beyond the time that the open enrollment closes. There is a $100 stipend that goes to any patient that has the HRA and the anchor program. And a very important understanding of this is that anybody enrolling will need to be willing to be randomized. In other words, some patients will get treatments and other patients will not get treatments. The reassurance piece is that if you were to develop anal cancer, that would be treated, that would be taken care of, and so on. Okay, Jeff. So the anchor program at DAP started about July 2019. There have been 80 patients that we've screened, and we currently have 38 patients that are randomized. And Joel's chart said it was 39, so I think we've added one since we made this. But, and again, these randomized patients, some are in treatment, some are in not treatment. We currently have 42 new patients that have shown a great interest to join the program. So we have a queue currently for people coming in. For us to qualify and to continue to be a half site, it's 58 patients to complete that. And we think with another HRA anoscopist and building the department, we would love to be able to become a full site and getting up to 116 people that are actually randomized. And I think that's the last one.
Get that goddamn link.
Yeah, that's the last slide. So that's my thumbnail about Anchor at DAP. I'm certainly open to questions from anybody on the on this panel that's interested.
Fucking can't get into the goddamn thing.
One
Great,
thing I will
thanks.
add, Dave, to David's comments is there is some reimbursement for time spent in the anchor study. So if you have a visit that involves a high resolution anoscopy, you'll get $100. And if you have a visit that doesn't involve a high resolution anoscopy, the reimbursement is $25.
And then there was a question in the chat, I don't know if it went to everybody, about the Gardasil vaccine in older people. So kind of our demographic, 50 and above.
What's the definition of older here before I get into trouble?
50. The official definition of aging with HIV is 50 and above.
Right.
Open to debate.
The Advisory Committee on Immunization Practices of the CDC has relaxed the permissions to give the vaccine. It used to be only up to age 26, and now they've said it can be up to age 45, but based on a one-on-one conversation with the provider, where the provider really sort of tries to get at the level of risk of that person, both in the past and going forward, because the vaccine only works to prevent initial infection with HPV. If you've had a lot of sexual partners, then the chances are you've already had those vaccine types. And if that's so, the vaccine will be safe, but it won't be very helpful. So if I'm, for instance, talking to a 35-year-old person, I'm going to try and understand how many sexual partners they've had and also what their thinking is regarding going forward, because if they think they're never going to have a new sexual partner and they think that their existing partner is also not going to have a new sexual partner, then the risk of getting a new HPV type is very low, and then there's nothing to protect against with the vaccine. So in my experience, most people over the age of 26 are not good vaccine candidates. There are always exceptions. And since the vaccine is safe, I do tell people it's not harmful, and if paying for it out of pocket is not a problem for you, then fine, it probably won't hurt you. I just don't know how much it's going to help. When all is said and done, I don't end up recommending the vaccine for too many people over the age of 30 or so.
Great, thank you. And then I know there are some therapeutic vaccines in the works, and I think you alluded to those on your disclosure slide. You would care to share what's going on with that?
So Gardasil is a preventive vaccine. The therapeutic vaccines that Jeff is alluding to are meant to be treatments for HSIL. So remember I said how you need that cell-mediated immune response to protect yourself against getting disease when you have HPV. So the idea of these therapeutic vaccines is to rev up that cell-mediated immune response. So if you already have HPV and you already have HSIL, when you get these vaccines, it's going to make the HSIL go away. That's the theory. Up to this point, the vaccines have been interesting and showing promise, but still not good enough. And we're getting better. I don't know whether there will be one that's ever good enough, but we are getting closer. And in fact, we just opened a new study in the AMC for a therapeutic vaccine made by Inovio. Some of you may have heard of that because that's one of the companies making a COVID-19 vaccine. And the other interesting thing about that vaccine is it's given in a slightly different way from most vaccines. So, you know, when you get a vaccine like a flu shot, you get a shot in the arm with a needle. With the Inovio vaccine, you get that, but a little more, because they put the little tiny needles in and then they deliver a pulse of electricity. So you're kind of getting, the technique is called electroporation, and you're getting a bit of an electric shock as you're getting your vaccination. It's not pleasant, I'm told, but it's not that bad. And to my knowledge, people don't drop out of the study after that, even though they know they need a total of 4 injections, actually, in the AMC study. So I'm told that when you're giving that injection, you just have to be really careful as the clinician, because sometimes, you know what happens when muscles contract, right? You go, whop. And so I know people who've been whacked when they've been giving the injection. Anyway, bottom line, not yet, but maybe sometime in the future.
Well, maybe you could recruit for that electroporation vaccine study during Folsom, and you might get more takers.
I'll keep that in mind, Jeff.
A suggestion from the community. Always here to help. Thank you. Any other questions or comments for Dr. Palefsky or Dr. Morris?
Can you clarify the treatment versus non-treatment arms of the anchor study?
Mhm. So so again, the computer decides which one you're going to go into. If you're put into the treatment arm, you're going to get the same kind of treatment you would get if you were just seen as a regular patient in a clinic. The only difference is that the study determines how often you're going to get treated. But the idea is that the clinician is going to try as hard as possible to get rid of all the high-grade disease he or she sees. So that's kind of like what's going to happen in real life. If you're put into the monitoring room, if the clinician at any time has concern that you've developed cancer, they're going to biopsy it and make sure that you don't have it. If you do, then of course you're taken out of the study right away and treated. Here, the idea is to follow people every 6 months. But if there's concern for cancer or progression to cancer, then the clinician will follow every 3 months. So you're followed very, very closely. And the idea is that the few people who will develop cancer, since you will have been seen 3 months earlier and deemed not to have cancer at the previous visit, if they find cancer at any point in time, in theory, it should be very early cancer. And some of these cancers, when they're early, can actually be treated the same way you treat HSIL. If they're more advanced than that, then the treatment is nasty and you need chemoradiation therapy for that. So we don't promise people that if they do develop cancer that it's going to be an early one, but our hope is that it will. And in that case, it's really no worse than having warts or high-grade disease treated.
Thank you.
Great. Any other questions or discussion? Yeah, Andrew, go ahead.
Yeah, I'm not interested in the electrostim aspect that Jeff suggests, but I'm curious, what is the point or value? What is that? Why is that part of the injection? That's
a good question.
It's a very unusual idea, and I was just like, well, what is that for?
Yeah, no, it's a great question. It isn't meant to torture people, but we know from the laboratory, you grow cells in tissue culture. One of the ways that you get DNA into cells, because it's the DNA that gets turned into the proteins that elicit the immune response. One of the ways to get DNA into cells is to break down the lining of the cell called the plasma membrane. And one way to do that is with electricity. When you give electricity to cells in tissue culture, it develops holes in the surface, and through the holes, the DNA goes into the cell and then does its thing. So the electroporation in the vaccine is the same thing, but at a patient level, because when you give the electricity, then the muscle cells that usually get the vaccine develop holes, and the contents of the vaccine can get into those cells better to make those proteins that then cause that immune response that hopefully will make the high-grade disease go away.
And I was curious, in terms of this initial screening, it seemed like from one of your charts, you have a large number of people who basically don't qualify for the study because they don't have HSIL.
Well,
so
yeah.
Is that what's initially screened if I were to come in?
Yeah, of course, we don't know who does and doesn't have it. So everybody is eligible for screening.
Right.
But if you don't have HSIL, then you wouldn't be enrolled in the study. But sometimes we do invite people to come back 6 months later or 12 months later because they may have developed HSIL in the meantime. And so we have rescreened a bunch of people.
Okay. But I gather as a large percentage of people who come in and don't have HSIL?
No, only half of people have it. So I would say that if you were screening for a study and you had a 50% chance of qualifying for it, I'd say that's pretty high, actually.
Okay, thank you.
Yeah, I know a lot of people who have trouble getting access to HRAs and screening, or their insurance doesn't like to pay for it. They have high copays, and the screening for the study is a good way to both enter the study and get the screening.
Thank you for saying that, Jeff, because that reminds me that in addition to the $100 that you get for your time, if you've had an HRA, the study will also pay your co-pays and deductibles related to any study-related activity, regardless of what kind of insurance you have. And if you don't have insurance at all, the study will pay for everything.
I have a question. Is there any indication of mortality rates that are directly related to anal cancer in the study or in other studies?
So nobody has died in our study from anal cancer or anything that we have done to prevent it. A fair number of people have actually died, but because we have a lot of very high-risk people in the study, but they've died of other things unrelated to anal cancer. I will say, I can't go into the details because we're presenting these to the Data and Safety Monitoring Board, but I will say that overall the study has been extremely safe so far. We thought it would be because we've had decades of experience with the treatment techniques that we're using. Complications are pretty rare. And so far that's been borne out in the Anchor study.
In its course, does anal cancer usually just become a cofactor in death? It's not the cause of death.
No, I think, well, we don't know because we always treat it as soon as we find it. We don't wait to find out. The way to answer that question would be to do something completely unethical, which would be to take a group of people with anal cancer and see how many die of it and see how many don't. But we think that most people will probably die of it if it's left untreated.
Yeah, this is Jeff, and I've had friends who died of anal cancer, HIV negative, going to good doctors, they're well off, had good insurance, but the doctors just didn't screen and it wasn't caught in time and ended up dying of it. So it does happen.
In its most severe cases, would it result in only like colestomy, or where does it go?
So if in the most severe cases, it metastasizes to the liver and to the lungs. So that's the usual cause of death, though sometimes it can grow so out of control in the pelvis that it blocks your kidneys and it blocks your bowels, so that even a colostomy doesn't help. It's a horrible disease, actually.
Yeah.
If I were to pick a cancer that I had to have, this would not be it.
So on that cheery note, any other questions? Now that we've heard from Debbie Downer. If no, we got some swag here. What have you got there, Jim? You're muted. Let me see. Anybody recognize what that is?
Yeah, it's an Anchor study for UCLA Care Center Anchor.
Oh, it's a water bottle. Okay,
It's
got
a water bottle. Yeah, there you go.
Okay, yeah. You get lots of other goodies too. Depending on where you are around the country, if you were in Miami, you get an umbrella, sunglasses, beach blanket. So
It's where I started. Now I'm at DAP.
okay, well, you should pressure Dr. Morris to make sure that you get good Palm Springs related stuff.
Thank you for sharing that. Great. Anybody else? If not, we'd like to thank Dr. Palefsky for joining us here in Palm Springs once again.
My pleasure.
Virtually, and Dr. Morris for letting us know what they're doing at DAP. And thank you all for joining, and we'll see you again next month.
Thanks, guys. Take care.
Thank
Have a
you,
good one,
Jeff.
everyone.
Bye.